Introduction. Welcome to this exploration of the embryology and surgical anatomy of the auricle. In this section, we will delve into the intricate development and structural characteristics of the ear, including its formation, significance, and surgical considerations. Chapter 1. Embryology of the auricle. The embryology of the auricle is intricately linked to the development of the lateral head and neck region, as well as the middle ear. In contrast, the inner ear develops largely independently. In the first 3 to 4 weeks, the head's development is guided by two key areas, the frontal head organizer and the posterolateral head organizer. The frontal organizer contributes to the formation of the forehead, nose, and intermaxillary bone, while the posterolateral organizer influences the development of the branchial arches, from which the ear will ultimately form. This convergence of developmental areas creates what is known as an embryological storm zone, where defects such as cleft lip or palate may arise. As development progresses, pharyngeal pouches and branchial clefts form, pushing into the mesenchyme and creating 5 distinct branchial arches by the end of week 5. Each arch develops its own cartilaginous skeleton, muscles, arteries, and nerves. The first arch, or mandibular arch, forms the lower jaw and certain ear bones, while the second arch, or hyoid arch, leads to the formation of structures like the stapes and the facial nerve. By the 6th week, small hillocks appear on the branchial arches, which will later develop into the auricle. The second arch plays a dominant role in forming key auricular features, while the first arch contributes to the tragus. As the auricle develops, it shifts in position from ventrocaudal to dorsocranial, explaining why malformed ears may be misaligned. Chapter 2. Surgical anatomy of the auricle. Despite its minor role in hearing, the auricle is a complex structure significant for aesthetic appearance. Accurate knowledge of its anatomy is crucial for reconstructive surgery, particularly in cases of congenital anomalies or ear loss. To assess the auricle's position, reference lines are established. The vertical profile line runs through the glabella and the upper lip, while the horizontal profile line intersects the Frankfurt horizontal plane. Measurements such as the distance from the vertical profile line to the trajan and from the trajan to the occiput help define the auricle's horizontal position. In adults, these distances average 102 mm and 93 mm, respectively. The vertical position is determined by the distance from the trajan to the vertex, averaging 137 mm. The axis of the auricle, or its greatest diameter, typically intersects the vertical profile line at an angle of about 10 degrees. From a frontal perspective, the auricle's width and visible surface area are crucial for aesthetic evaluation. Studies indicate the average auricular width is around 20 mm, with slight variations over a lifetime. Chapter 3. Individual structural features. The auricle consists of various prominences and depressions, including the helix, antihelix, tragus, and cavum conchae, each requiring detailed anatomical knowledge for corrective surgery. The lobule, in contrast, lacks a cartilaginous structure and consists mainly of fatty connective tissue. Thickness measurements of various auricular layers are important for achieving aesthetically pleasing reconstructions. In summary, understanding the embryology and surgical anatomy of the auricle is essential for effective medical practice. The intricate details of its development and structure not only inform surgical techniques but also enhance our appreciation of this remarkable feature of human anatomy. Thank you for listening.